Good afternoon, everybody. This is our last session of our last day of this knowledgeable meeting that we had in the past 3 days. And it is my pleasure to present Professor Ali Mir Sadat from Imam Abdul Rahman bin Faisal University in the Eastern Province. He is a good friend of mine and of the Osteoporosis Society and of all of us, I'm sure. And he is one of the maybe few orthopedic surgeons that they have great interest in osteoporosis, and one of the pillars of that. So he's going to talk to us about the gap in fracture care in Saudi Arabia. Professor, please.
Thank you very much, Dr. Hazem, Chairman. It's good before the internists and the endocrinologists come, we should finish this chapter. Because whatever I'm going to talk, it will upset them. At least we are in majority, 3 orthopedic surgeons are sitting here. As usual, these are the disclosures, nothing related to the topic I'm talking about. But here, this has to be emphasized that the opinions expressed is personal, not based on anything else, not based on what is going on in the country. Now, despite the advances of osteoporosis in the last 20 years, and in the last 20 years, the incidence of osteoporosis has also grown, but still, a large group of patients being left undertreated or even not treated at all. So this group is called as the treatment gap, where patient is known to have osteoporosis and they're not getting the treatment. Now, I'm sure Hazem will recognize, and even Dr. Shakir, this old Smith-Peterson nail, which I used to do in 80s in UK, had one fracture, then in 3 months' time, patient will come back with the other fracture. The same thing is being repeated even now. This is the X-ray of 2020. This is a male patient who had a fracture of the left hip. This was fixed. Patient went home, came back in 4 months' time with a fracture of the right hip because he had no treatment. Again, the orthopedic surgeons were interested to put an artificial hip, and patient went back home. Before the fracture, he was walking. After the 2 fractures, this patient's mobility was on a wheelchair. So if this patient was treated properly, probably he would not have a second fracture. Now, before I present you to the treatment gap, I will tell you exactly what is happening in the world, because when we see the world, always people say, oh, Saudi Arabia is the worst, we don't treat patients properly, and then the best treatment is in US and Europe. So I just want to show it to you that mistakes are committed everywhere, not only here. This was the first study which was published in the Journal of American Geriatric Society in 2010. Patients involved was 51,000 patients, including 318 hospitals. They found that only 7.5% of the patients post-fragility fracture had treatment. Only 7.5. So top of the world, the best country, all treatments are good. This is what they were doing. Then in 2014, another study was published from Richmond, Virginia. Here they found that even after 90 days of the treatment, only 18% had the proper treatment, like a bisphosphonate or anabolic agent, vitamin D and calcium. Canada was not far from them. In Canada, even today, 20% of the patients don't receive the correct treatment for osteoporosis post-fragility fracture. Now, what about Europe? I know Eugene is not here, McCloskey. he recently published in Osteoporosis International in 2021. They did about 12 EU countries and found the average treatment gap was 75%, with a range of 53% in Ireland to 91% in Germany. That means the treatment gap is universal, not only in one country, but most of the Western countries. So then I came back, what is the situation in Saudi Arabia? Unfortunately, not many studies are here. All the literature search which I did, we found 2 studies from our institution. One, Professor Mona is sitting here, and then one came from Dr. Yusuf Al-Saleh's group in 2020. I'll go in each, what happened, how did the percentage was there before, what was fall. Let me tell you one thing, that a DEXA is not part of the standard treatment for post-fragility fracture. You do DEXA only to have monitoring the treatment, whether the patient is improving or not. Now in January 1 and 2011, we did this particular study. All patients who had fragility fractures were over the age of 55 were included in this study. And then we had, in 2001, we found that only 15% of the patients had even a vitamin D test post-fragility fracture. Again, as I said, DEXA I will not consider as part of the treatment. Initial treatment is only for monitoring. Now, these are the post-fixation treatment was given. This is the different percentages. Vitamin D alone, vitamin D plus calcium, and then bisphosphonate and anabolic agent. What happened was initially in 2001, our own treatment gap was about 81%. Like 81% of the patients who had a fragility hip fracture or spine fracture did not receive the treatment. But by 2011, this dropped to 20%. I'll tell you how it happened. At the same time, this males being neglected is a standard everywhere across the board. In the study of Dr. Yusuf, the study of our own center, study of all European and American studies say the same, that the females, if they have a fragility fracture, they think this is osteoporosis. Males have been neglected to get the proper treatment. Now, here I'll appreciate this, that in 2001, our gap was 80%. Then by 2011, we brought it down to about 25% or 28% it was. Now, what we did was, I will come back to how we managed that. But in the study of Dr. Yusuf, it came out that, again, BMD testing initially was 5.7%. Post-surgery, it increased to 12%. Now, these are the number of the different drugs they were using. And they found that 66% of their patients who had a fragility fracture had no treatment for osteoporosis. It's a huge gap. These patients, in the next coming 6 to 8 months, they can have a second fracture. Now, our own second follow-up of the study, in 2019, we published this particular study. We found that our gap further reduced to combination of about 25.46%. From 30% in 2011, we further dropped. They were group 1, 2, 3, 4, we classified accordingly. Those who had bisphosphonate, those who have teriparatide. We usually don't give bisphosphonate post-fragility fracture. We always relied on anabolic agent. Now, Professor Foda is here. This study came from there. There again, incidence of fragility fracture they reported was 16.27 per thousand, but this is a huge number increase on what we have been seeing before. The DEXA was ordered in only 26%, and the DEXA scan was ordered for hip fracture, significantly more in women than men. This is what I've been seeing across the different studies, that men are treated less post-fragility fracture, women are treated, in a comparative way. We know that every patient who comes to the emergency room from a headache to MI is getting treated. Patients with fragility fractures are not treated. No treatment is given. What is happening? Where things are going wrong? Now, in 2001, what we used to do when our gap was 80%, we used to fix the fracture, patient admitted to the orthopedic ward, and once the surgery is done, we used to transfer this patient with an appointment slip to go either to the internist or to the endocrinologist. And also during that period, there was pharmacy restrictions from in the hospital that the residents cannot prescribe the medication, osteoporotic medication, and usually patients are discharged in the afternoon when the consultants are not there. And you cannot give your password to them to use it in the patient care system, so they were getting discharged. But we changed the strategy in the institution. We said, no, the osteoporosis treatment should be done, the medication should be prescribed by the orthopedic surgeons, not by internists, because we are having a treatment gap. That happened because we felt that in the osteoporosis management of fragility fracture, orthopedic surgeons belong in the center of the puzzle, not in one corner. If orthopedic surgeons fix the fracture, they have every right to write the medication for the patient and to follow up the patient. This strategy made us to drop the treatment gap from 80% to 25%. Now, in 2007, in that particular study, the first study, we found that the drop came to 30%. Now, still at 2020, still there is a gap of 25%. Now, this is why it's happening is, again, at the time of the discharge, even though when we do the rounds in the morning, we tell the residents, okay, this patient is going to go home, and then this patient should receive so-and-so treatment. And we log off. And then when the time the resident sits for writing the discharge summary, entering the drugs, he finds out that he cannot enter the drugs because he does not have the privilege to enter the drugs. That still we are trying to take care of that. Now, a couple of years ago, the Fracture Liaison Service came, the program, but I believe that the Fracture Liaison Service in itself will not bring down the gap because it's a program. Who's running the program? The doctors are running the program. The team is running the program. For that particular team of Fracture Liaison Service, you need somebody who is competent, somebody who is committed, who's dedicated to osteoporosis treatment. And without that, I don't think the Fracture Liaison Service will work. And always I am saying again and again that target the front line who are managing the fragility fractures, and those are the orthopedic surgeons. Now, I have been telling this last 20 years, management of osteoporosis in 90% of the cases is not a rocket science. We have got only 4 or 5 drugs. Vitamin D and calcium we can manage. In case if we cannot manage, we need consultation from our colleagues in the endocrine or intern who is doing it. And I think, I have recommended to the Saudi Council also that osteoporosis management training special sessions should be part of the residency training programs. If that happens, everybody will have an interest. Now, our patient care system had before Quadrimed, now we changed to a new system called Felix. And I am working with the IT department where we can use the artificial intelligence, 2-3 keywords, a fragility fracture, fractured neck or femur, a patient more than 50 years, automatically they will enter the drugs, calcium, vitamin D, and whatever drugs it's available. That can happen. Or even the system can flag that this patient cannot be discharged without these medications. We are trying to work with them. I hope it will work out. Now, 2015, I just want to bring this in the treatment gap. We assessed that the total yearly cost of treating fragility fracture femur alone is about 2.3 billion Saudi riyals for a population of 30 million. And by 2025, this will reach to 35 billion for only one fracture. Now, this was assessed as 5.6 femoral fractures per 1,000 population. Now, this I'm quoting, Professor Mona will answer this. In their paper, they mention our estimation of 6 per 1,000 and the cost is underestimated. And in their study, they had 16 per 1,000 femoral fractures, that is a little bit higher, similar like what we see in UK. So if our estimate of 35 billion riyals for 2030 for femoral fractures is low, this suggestion might be it's much more higher, I don't know. So what we need to do is, time has come really, we have to stop the secondary fractures. Primary fracture, the first fracture is paramount, there's no doubt about it. But the second fracture, which happens about 20 to 22%, we can at least limit that by stopping this or limiting this treatment gap. And the mortality of the first fracture is 25%. In our own study in our hospital, we found it was 28%. But after a second fracture, this can go to 50%. And I think that the first fracture could be because of a patient's fall because of a slippery slope. But as I said, that the fractures post-second fracture is 50%. Here, I think the physicians are responsible that the patient was on the top of there. We did not treat the patient properly. We did not stop the treatment gap. And then the patient went down the hill. The mortality increases. The morbidity increases. They are unable to they usually lose one step down. If somebody who was walking regularly, he will take a cane. Those who are walking with the cane will go on a wheelchair. Those who are on a wheelchair will go on the bed. So this here, I think the physicians are responsible of not treating the patients properly. So my belief is that we target the orthopedic surgeons to start the treatment post-fracture, and we can bring the treatment gap in post-fragility fracture. We can reduce the cost, mortality, and morbidity. And not one department alone can do this work. It has to be a combined teamwork, and then only we can achieve. Irrespective who heads the team. We don't want internist or anybody endocrine or orthopedics to head the team, but we need two portions. To shake the hands, we need two hands. One is the administration, one is the physician. If both cannot come together, we cannot shake the hands. Thank you very much.